So now we'll be seeing retroperitoneum. So before starting, I would like to thank Chandana Shri Ma'am for sharing these wonderful notes with us, which are very helpful for quick revision. And the link for the notes is given in the discussion below. You can download it from there. So basics of retroperitoneum and some disease of the retroperitoneum. So first of all, we'll consider the anatomy. So let's get started. The anatomy, that retroperitoneal space is the space from the diaphragm to the pelvic floor, and that is from T12, 12th rib, T12, and extending up to levator ani, that is the pelvic floor. Anteriorly, it is having peritoneum, and posteriorly, we have the posteroparietal wall of the abdominal cavity along with the spine and the paraspinal muscles. So it is divided into two parts. So the upper part is the lumbar fossa, which extends from the T12 to the base of sacrum, the iliac crest and the iliolumbar ligament, and it is lined posteriorly by the fascia covering the quadratus lumborum muscle and the psoas major muscle. So what are the contents? So it contains the alveolar tissue, adrenal gland, kidneys, the colon, the ascending and the descending, duodenum, ureters, kidney vessels and gonadal vessels, IVC and aorta. So these are the contents. Considering the below part, which is the iliac fossa, which is continuous above with the lumbar fossa superiorly, and laterally it is, and anteriorly the preperitoneal spaces and pelvis inferiorly. Posterior wall is by the iliacus muscle with its fascia. The content is the iliac vessel after continuing from the IVC and the aorta, ureters, genitofemoral nerve, gonadal vessels, and iliac lymph nodes. We can consider the space as anterior space. So these spaces behind the peritoneum. So this is divided, the retroperitoneum is further divided into three, especially the lumbar fossa. That is the, just besides the kidney is the perirenal space, which has the kidneys, adrenal and the aorta part. The anterior to it is the anterior pararenal space, which has the ascending, descending colon, duodenum and pancreas, and posterior pararenal space, which is in continuity with the preperitoneal space. It has the fat, and it is bounded posteriorly by the transversalis fascia and the thoracolumbar fascia. As we can see in this diagram properly, so the ascending colon, duodenum, and the descending colon, as we can see in the diagram, is in the anterior pararenal space. Also, it includes the pancreas. And in the perirenal space, the perirenal fascia, inside the perirenal fascia, we have the kidneys and the aorta and the IVC. And the posterior pararenal space, we have the fatty tissue, as you can see in the diagram, which is bounded posteriorly by the thoracolumbar fascia and the transversalis fascia posteriorly. Now considering the zones of retroperitoneum in regard to the injury. So what are the zones of retroperitoneum? So zone 1, there are three zones, 1, 2 and 3. Zone 1 is the centromedian zone, which is this part, which has the main major vessels, the abdominal aorta with the bifurcation, the IVC with the bifurcation, and pancreas and duodenum. So it is very important that even blunt injury to the centromedian zone, that is the zone 1, we need to explore depending on the clinical scenario. But there are high chance that there will be hemoperitoneum, so we have to consider. Penetrating injury in any of these zones we have to explore considering the clinical scenario. Now seeing the second zone, that is the zone 2, that is the lateral part, which includes the kidney, adrenal, ureters and the colon, that is ascending and the descending colon. And the last one is the zone 3, that is pelvis, which includes the iliac vessel and the rectosigmoid and the other organs. So we have to consider the damage when in case of trauma. So penetrating injury in any of the zones, we need to explore depending on the scenario, the vitals. And blunt injury in the centromedial zone, even then we will need to explore depending on the vitals and the clinical scenario. So considering the nerves of the retroperitoneum, we have 6 of them. So what are these? The iliohypogastric, ilioinguinal, genitofemoral, lateral femoral cutaneous, obturator and femoral nerve. Now considering the lymphatics, that is the aortic group, caval group and the pelvic group. So aortic group is the pre-aortic near the celiac artery, the retroaortic and the para-aortic. Then the caval group, that is the pre-caval, retrocaval and paracaval group. And then we have the between one, that is the aortocaval group. In the pelvis, we have the common iliac, external iliac, internal iliac, also known as hypogastric, obturator and sacral. Now considering the approaches for the retroperitoneum. So first and foremost is the intra-abdominal or transperitoneal approach. For considering the right-sided structures, we have the cattle manure or the cattle brash manure, which is for the right-sided structure and the infrarenal great vessels. So here what we do is we incise the lateral peritoneum along the cecum, ascending colon and hepatic flexure through the white line of Todd and Kocherization of the duodenum and mobilize the structures, right-sided structures anteromedially. So we can assess the right-sided structures on the right side, that is the right kidney and the adrenal colon and also the infrarenal great vessels. Then second is the Mattox manure, which is for the left-sided structure and the suprarenal great vessels. So here we incise the lateral peritoneum along the sigmoid descending colon and splenic flexure through the white line of Todd, mobilize the spleen, pancreatic tail and stomach as per need and mobilize the left-sided structures which we have incised, that is the colon and the flexures, splenic flexure on the anteromedially so as to check the structures on the left side, that is the left kidney and the suprarenal great vessels. Then the posterior approach, which is preferable because there will be less post-op ileus, intra-abdominal adhesion and respiratory complication in this approach. So it has to be considered, especially when it is an elective surgery. Then the laparoscopic approach, the retroperitoneoscopic approach. These are some of the approaches. Now considering the retroperitoneal abscess, which could be primary or secondary. Secondary is the most common due to infection in the adjacent surrounding organ. So primary, it generally occurs when there is a hematogenous spread or due to Staph aureus, which is common and it is generally monomicrobial and later results in sepsis. So what are the most common sources of infection for retroperitoneum? Is the kidney most of the time, that is around 47 to 50%, as the complication of kidney stones resulting in pyonephrosis, pyelonephritis or UTI associated with urosurgeries resulting in pyonephric abscess, perinephric abscess, spreading to the renal fascia and then tracking to the retroperitoneum. So organisms involved are the E. coli, Proteus, and generally it is monomicrobial. And then the causes for the GI, that is the retrocecal appendicular abscess, diverticulitis, Crohn's disease, pancreatitis, and these are generally multibacterial in case of GI infections causing due to E. coli, enterococci and bacteroids. Spine and bone infection through the TB spine, it is also a cause. Trauma, complication of surgical procedure is also a cause. Then the clinical features, signs of sepsis, fever, malaise, weight loss, specific to the location, could be abdominal or flank pain radiating to groin, labia and scrotum. Psoas abscess, radiating preferred pain to the hip, thigh, knee, and can also track up to thigh. Imaging is contrast enhanced CT scan is the gold standard. And even ultrasound can give us some picture. Treatment will be antibiotics when it is small small, it can always be sometimes be managed by plain antibiotics, only antibiotics. If it is large, causing more symptoms, then drainage, which could be percutaneous or surgical open, laparoscopic, and other treatment of the cause. Then retroperitoneal hematoma, which are caused due to blunt or penetrating trauma, especially over the kidney, spleen, or the vessels. Abdominal aortic aneurysm causing rupture, or anticoagulation of fibrinolytic therapy, blood disorders, dyscrasias. And as you have seen the zone 1, 2, and 3, where zone 1 has the abdominal aorta IVC and the pancreas and duodenum. The zone 2, which has the kidneys, adrenal, and ureter with the ascending and descending colon. Zone 3 is the pelvis part. To be understood that these zones are not to be confused with the spaces which we have seen, the pararenal space and the perirenal space and the posterior pararenal space, anterior pararenal, posterior pararenal, and perirenal space. So these spaces are considered anteroposteriorly, whereas these zones are considered in a coronal section, coronal plane, to be more precise. And injuries to zone 1, that is centromedial zone, where the hematoma needs surgical exploration because it is great vessels and higher chance of severe injury causing death. Zone 2, where there is renal source, so we have to explore in case of expanding hematoma. Zone 3, due to pelvic fracture, should not be explored unless there is severe hemorrhage causing unstable vitals. So we have to consider the clinical scenario. Then we come to the retroperitoneal fibrosis, which is a rare disease, but just for sake of the topic, we'll have its discussion. So inflammation and fibrosis of the retroperitoneal tissue, which could be primary or idiopathic or secondary. Primary is more common, also known as Ormond's disease, which is immune mediated. It may be associated with other autoimmune disorders like ankylosing spondylitis, AS, SLE, systemic lupus erythematosus, Wagner's disease, PAN, polyarteritis nodosa, IG4 disease. Then it is associated with HLA-DR-B1 allele association. It will also be associated sometimes with diabetes type 1, myasthenia, Hashimoto's, more common in males, commonly in old age, 50 to 60 years. And these are some of the features of the primary one. The secondary, that is 30%, could be due to aortic aneurysm, pancreatitis, drugs like ergot, beta blockers, hydralazine, methyl dopa, malignancy, lymphoma, carcinoid sarcoma, colorectal cancer, breast cancer, infection like TB, radiation, retroperitoneal hematoma, surgery, asbestos exposure, even tobacco. So these are some of the causes. So it starts as chronic periaortic aortitis, affecting the retroperitoneal tissue near the large arteries, expanding fibrosis, encases ureter, IVC aorta, mesenteric vessels, sympathetic nerves. So there will be bilateral involvement generally in 70% cases. So it starts from chronic periaortitis, so around the aorta, spreading around other organs. Then clinical feature is pain, anorexia, weight loss, ureteral obstruction causing hydronephrosis, uropathy, obstructive uropathy, then renal artery impingement causing hypertension, lower extremity edema due to lymphatic blockage, decreased pulses, hydrocele due to lymphatic obstruction, varicocele due to gonadal vessel involvement. Diagnosis will be through raised ESR, CRP, and ANA. Clinical imaging in the form of CECT, which will show fibrotic retroperitoneal tissue similar to the attenuation to the muscle, and contrast will help us in degree and extent of the encasement of the vessel. So contrast and CT scan is the investigation of choice. Then for treatment for the ureteral obstruction, we will go with ureterolysis, stenting, and if needed, surgery. Then For medical management, we have corticosteroid, tamoxifen, methotrexate, azathioprine, and cyclophosphamide, which are the immunosuppressant drugs. So this was the treatment of the retroperitoneal fibrosis. Then we see the retroperitoneal tumor. So what are the various causes? So it could be due to primary neoplasm of the retroperitoneal organ and extracapsular growth of this neoplasm from the kidney, adrenal, colon, pancreas, primary germ cell neoplasm from the embryonic tissue, which will have alpha fetoprotein, HCG, LDH increased, lymphoma from the retroperitoneal lymphatics with B symptoms, metastasis to retroperitoneal lymph node, and soft tissue tumor of the retroperitoneum could be sarcoma dermoid. So most common primary malignant tumor of retroperitoneum is sarcoma. So the retroperitoneal sarcoma, which is most commonly liposarcoma or leiomyosarcoma, risk factors being neurofibroma, radiation, and Li-Fraumeni syndrome, and hereditary retinoblastoma. Then clinical feature, which could be asymptomatic abdominal mass, pain, weight loss, lower limb edema, paresthesia, paresis. Evaluation generally is done through the imaging, that is the CT or the MRI with contrast. Biopsy, if it is generally a retroperitoneal sarcoma, it is generally not done. If it is resectable, staging, where T0 is there is no evidence of primary, T1 less than 5 centimeter tumor, T2 5 to 10 centimeter, T3 10 to 15 centimeter, T4 more than 15 centimeter. And nodal involvement, where N1 is the regional nodal spread and M1 is the distant metastasis. And the grade, the differentiation of the tumor, the G, that is tumor differentiation, necrosis, and the mitotic count. G1, where there will be score is 2 to 3, G2 where there is 4 to 5, and G3 where it is 6 to 8, depending on the factor above discussed, like the tumor differentiation, necrosis, and the mitotic count. Then considering the stages, stage grouping, that is T1 is stage 1A, T2, T3, T4 is stage 1B, with, and both these are with grade 1 histology. Then stage 2, T1 with grade 2 or 3 histology, and T2 with grade 2, grade 3 histology is stage 3A, and T3, T4 with grade 3 or grade 2 histology is stage 3B. And lastly, either it is M1 or it is nodal spread. So that will result in stage 4 tumor. And treatment is surgical excision followed by intraop radiotherapy if needed, and followed by radiotherapy and chemotherapy. So this was all about retroperitoneum anatomy and retroperitoneal disorders. Hope it has been understood and it will be helpful for quick revision. Thank you for watching. Please like, share, and subscribe. Never give up, because great things take time. Keep studying, keep growing. See you in next video. Thank you.